Yeah. Well, welcome everyone. It's my pleasure to introduce Dr. David Mizrahi to the U.S. Cancer Center community. Dr. Mizrahi is a research fellow at the Daffodil Centre at University of Sydney, Australia. He's an exercise physiologist with research interests in the area of physical activity during and after cancer treatment for both adult and pediatric cancer survivors. Dr. Mizrahi is the chair of the Clinical Oncology Society of Australia Exercise and Cancer Committee. He's also recently completed a Fulbright scholarship with St. Jude's Children's Hospital in Memphis, Tennessee. We are very thankful to him for accommodating this talk for us during his vacation with his family. So thank you, Dr. Mizrahi, and welcome. Over to you. Thanks.
This one. Thank you for having me today. It's a real pleasure to be here on my holiday, actually back from Memphis. I spent the last 4 months in Memphis on a Fulbright fellowship, which is an exchange program between the US and the rest of the world. It's been a phenomenal time here. I've traveled all over to Pennsylvania and San Diego and Arkansas. And I went to Holland for 3 days and now here on the way home. So it's a really exciting time to finish. We're actually staying up in the North Shore with my family. Beautiful up there, really enjoying our time here. And yeah, really a pleasure to be here to talk about my work. I'm still a little bit in holiday mode, so I'll apologize in advance if I'm still very relaxed. And I'm very excited to wear my closest to Hawaiian shirt that I have in my, I love it. I think it's fantastic. So my topic today, it's about the concept of exercise oncology. So exercise for cancer patients and survivors. And I'll talk about the current evidence that there is for children and adults. And also, this is the real big winning ticket. How do we embed exercise into cancer care? So as a background, I'm a research fellow, as mentioned. I do clinical work with kids and adults. I also do research with large data sets, and I have worked clinically as well. I guess a little bit of a quick snippet background to how I got into this position. I give talks sometimes at like high school careers days, and I tell them I have no clue how I got into this position or that this role even existed. But basically, I used to like exercise. I love exercise. I'm a soccer player, a cricket player, rugby player. And I got into this field of exercise physiology, which is really growing in Australia, where you can work with all sorts of chronic diseases and help them via exercise. Exercises, it helps so many different conditions. And at the end of that program, I enrolled in a research degree, a master's, where we looked at how exercise could help women with relapsed ovarian cancer during their chemotherapy. It's a tricky condition to work with. There's a lot of treatments. I really got thrown in at the deep end, but there's a lot of benefits to be had when you're going through that type of treatment. And then after that, I worked at the Sydney Children's Hospital as a research manager looking at clinical trials, nothing to do with exercise at all, but looking at new therapies and new drugs for these kids. And whilst I was working there, I noticed that nearly none of these kids are getting any sort of rehab, except maybe like 5 or 10% that have really high needs, like brain tumors or amputations, and that really, really need rehab. But the rest of these kids aren't getting any support. And I thought, this is not right. Kids need to be running around, being active, because after 2 years of treatment, go back to school and already playing catch up the rest of their lives to their peers. So I decided to do a PhD in that space and try to learn a bit more about the role of exercise for children's cancers. And then after then, I've done postdocs, so learning about specific conditions. So I'll speak about my work with cancer and neuropathy. So it's nerve damage from cancer treatment. I'm academic, so I like to do teaching all around Australia and now around the US. And I guess the latest thing as well is I'm chair of the COSA, which is like the ASCO equivalent, so the Clinical Oncology Society of Australia, their exercise and cancer committee. So we're trying to put exercise on the map in Australia and cancer care. Also today, if you have any questions throughout, please just raise your hand and we can make a discussion. I'm more than happy to do that. So I'll give a little bit of a background statistics and treatment, which you're probably all aware of, but I guess I'll relate it to the role and importance of exercise, and then talking about exercise both during and after treatment, and then a discussion. I like to open my talk by saying I have this uncle, and on dinners when we see them once a month, he always says, "David, when are they going to find the cure for cancer?" And I say, "Uncle Rob, firstly, that's not even my job. I'm in the lab looking for a new drug. He just thinks that's what he thinks I do." But at least for exercise, what is the best exercise for cancer is a question that comes up a lot. But as you can see up here, it's not an easy question to answer because there's over 100 different types of cancers or subtypes or different stages, or they can present at different times. They can come back. You can have different treatments that affect different organs. So you might need different types of exercises and different doses, and that could change as well over time. So it's not a simple answer. Also, personal preference is important, but all different ages, all different interests in exercise as well. So we have to really adopt a personalized approach. And in children as well, this is complicated because there's many different types of cancers for children, most common being leukemia, which is about a third of the time. And even then you have a leukemia that has a better prognosis, ALL, acute lymphoblastic leukemia, which is about 90% surviving, which is great. Then you have AML, which is a more aggressive leukemia. It's only about 60% are surviving, and a much more intensive treatment regimen. So they have different outcomes, even though they're both leukemias. There's lots of the proportions of brain tumors, and brain tumors, you have a lot of significant issues and comorbidities from treatment. So what exercises you give for a child with brain tumor might be very different to what you give to leukemia. Also, for children, it's very rare. So in Australia, actually in the world, it's only about 1% of all cancers. So it's actually very rare. In Australia, we get about 1,200 diagnoses per year across the whole country. And our country is nearly the same size as the US, about 80% of the landmass. So if you do the maths, it's spread out all over the country. So in terms of having specialized care for this population, it's very difficult to do en masse with such a small population. We know that the main treatment types for cancers, so surgery, chemo, radiation, hormonal therapy, immunotherapy, can cause a range of different comorbidities affecting nearly all bodily systems. So major things we're thinking about is cardiovascular system, and then gastrointestinal. Talking about short term, we're talking about long term. That can both impair your ability to do exercise or make it harder, or cause you issues in the future, which we can call late effects. That we know that maybe if we're fitter and more active and have better cardiovascular health, we might be able to cope with treatment better. You probably all know about this, but I guess why I'm speaking about this is in terms of individualizing exercise prescription, is that we know that if chemo is going to be 3 to 6 months or whatever it might be, it can be given in cycles, 1 week, 2 week, 3 week, 4 week. And why this is important for exercise is because we need to talk to our patients and say, when are you feeling the best and when are you feeling the worst? Because, if you're feeling really bad for 1 week after treatment, maybe we can have an easier program in that 1 week. And then the rest of the time we can ramp it up. So you can have a program A and a program B, rather than just saying, okay, go and do your 30 minutes per day or 3 times a week or whatever it might be. It really has to be tailored, because in that week after treatment, it might be feeling really bad. But it's better than doing nothing at all. Very busy slide here, but what I want to point to the fact is there's lots of different types of chemotherapies, and it's really important to ask the patients or find out what type of treatments are being prescribed, because each treatment can have different toxicities during and after treatment. So for example, the rubicins, doxorubicin, and those type of anthracycline class drugs, we know that cardiovascular disease is a big issue after receiving these treatments. So, maybe we can do aerobic exercise, things like walking or cycling during treatment to strengthen the heart and protect the heart from getting heart disease. And we're seeing this now more in research, that people are doing exercise during treatment, and in mice as well, they're exercising them during this treatment, and it's protecting the heart, and they're less likely to get heart disease. Then we have other treatments like taxanes or other vinca alkaloids that can cause nerve damage during treatment. So I'll talk about this one as well, but patients can have issues with picking up things or balance issues. So we know that if these issues are going to occur, maybe we can do some targeted exercise in advance to help mitigate these issues from occurring, rather than waiting 6 months and then starting exercise later where all these issues have occurred. Radiotherapy is every day for 6 weeks. It's quite an intensive treatment regimen. So, we can try schedule exercise before. Like, again, it's participant preference. For me, it's like the theme or the motto is some is better than none. The exercise guidelines, 30 minutes times 5 a week, that's a lot. But if you can just do 5 minutes of walking, if you're a non-exerciser and 5 minutes of walking, that's fine for me. Go for a small walk around the block, some squats at home. Maybe the next week we can do 7 minutes a week. The next week we can do 10 minutes a week. But the problem is if people look at those health guidelines and they say, I can't do 30 minutes of exercise, it's not going to happen, and they do nothing. So rather something is better than nothing, and then slowly ramp it up over time. Again, going back to the side effects of treatment, we know that in general, people are going to lose muscle mass, have worse fitness, worse physical function, so ability to do general life tasks, shopping, cooking, cleaning, picking up grandkids, worse bone health, immune function, sleep quality, quality of life. All these important things for daily functioning are going to be impaired. Fatigue is one of the most persistent and complained about issues. But actually, there's evidence that exercise can improve all these things during and after treatment. Exercise can give you more muscle mass and better physical function and better fitness, less fatigue. And that's a really big one, fatigue. Because a lot of people will say, well, I'm too tired to start exercising. But they're thinking about in the gym, going to the gym is a big deal. But maybe you can just do 5 minutes walking at home or 5 minutes of squats or small amounts of squats and slowly build up, particularly if you're a non-exerciser and getting into it that way, which is really challenging. So this one, CIPN, let's call it, because it's a mouthful, calling it chemotherapy-induced peripheral neuropathy. It's a big issue in many different types of cancers. So breast cancer, colorectal cancer, gynecological cancers, lung cancers. They receive these types of treatments, and they can have nearly 70% of patients can experience these symptoms during treatment. And if the symptoms get too bad, the clinicians often reduce their treatment or stop their treatment altogether. Now, that's a big problem because sometimes people don't want to stop their treatment. They want to have their full dose so they have the best chance of beating their cancer with the treatment that was prescribed. And often patients will have these symptoms after treatment. And then in some cases, in rare cases, it's permanent. It doesn't go away. So these neurological symptoms I'm talking about are numbness in the periphery, so in the hands and the feet, losing sensation. It can be discomfort. It can be tingling. It can be pain. It can be balance and walking problems. Now, if you're talking about a 35-year-old breast cancer patient and she's got difficulty picking up things, I'm not as concerned about a 70-year-old breast cancer patient who can't feel her feet, which means going for a walk on a footpath gives her anxiety because she's got fear of falling over. Now, that's, for me, an issue because now she becomes a falls risk and a fractures risk. So I'd be thinking, balanced exercises, lower leg strength exercises, some walking on the treadmill. So if she's got the arm rails, so it's safe, controlled, build up that confidence. That's really important as well in this population. Balance exercises in terms of static, so standing still, but also balance exercises that might be dynamic to replicate real life movements. Really important. And it's important in this population to act on this neurological cascade because these symptoms can cause worse balance, worse posture, which will decrease their gait speed, so their walking speed, which can then lead to decreased physical activity participation, which will lead to that muscle deconditioning, fitness deconditioning, fear of falling, worse independence in doing activities at home. And that cycle just gets worse and worse. So we just have to intervene at any point. Now, I think what's important is going back to what I was saying originally, is we don't want to wait 6 months till people have finished treatment. because that can be a common thing that people say, I'll wait till I'm finished, because fair enough, there's lots going on in their lives. Facing the uncertainty and going through treatment is a big life experience. But why not start earlier and prevent these declines from occurring when we know it's probably going to help? And cardiovascular disease is a big issue as well. Now we're seeing more and more people surviving breast cancer treatment, for example, but instead of the cancer being the cause of mortality, it's now cardiovascular disease on the rise from all these different treatments, and then the side effects that occurs, and also the changes in body composition and metabolic progress and your lifestyle changes as well. So again, can we be proactive and mitigate all these things from occurring and reduce the likelihood of cardiovascular disease? That would be fantastic. And I guess here's just a figure to back up a study from a few years ago. I didn't cite, I'm sorry. That shows a decrease in breast cancer mortality, but increase in cardiovascular disease. I've been alluding to this anyway, but the role of exercise oncology is increasing. We're seeing more and more institutions and organizations endorsing the role of exercise. So we've had COSA in Australia, we've had ASCO now in the US come out and say all patients should be active during and after treatment. This is, I guess, talking about prevention now in this study, saying that there is a lot of evidence now to show that if you're active before being diagnosed, we can actually, there's a lower likelihood of developing a range of different cancers. So strong evidence for colon, breast, endometrial, kidney, bladder, stomach. But unfortunately, that we need a public health message to say, everyone should be active. And often people get diagnosed, and that's the teachable moment that we can work with patients after they've actually been diagnosed. So after they've been diagnosed, this big meta-analysis came out a few years ago to show there's actually a nearly 1/3 lower risk of recurrence of the cancer coming back if you're meeting those 150 minutes a week moderate to vigorous activity guidelines. So that's, when working with patients, that's often, or even talking to clinicians and nurses, that's often a really important educational point to say, well, there's a lower risk of the cancer coming back. And that's a really powerful thing as well, because exercise is something you can control and anyone can do it. You don't need a gym membership. You can have a gym membership. It's great if you do. But, we can do a lot of things at home as well for little or no money at all. And also there's nearly up to 50% lower risk of all-cause mortality, because it's not going to just help the cancer outcomes, it's going to help cardiovascular, metabolic, a range of other physical outcomes. This study, I guess, is a consensus statement, has basically said, when people age, we expect them to have reductions in their muscle strength and increases in fatigue, but cancer will accelerate all these declines. So it's really important for cancer patients, during their treatment, we need to assess their physical function. We need to see where they're at, what they can do physically. Look at their strength, look at their fitness, their functional capacity. Are there any deficits compared to, age and gender percentiles? And then we can see if there's anything we should focus on in our exercise programs. All this evidence I'm presenting is really in adults. So the children's literature is way more behind because, as I mentioned, there's not many childhood cancer patients and they're protected with research. So it's very difficult to do good research in the population. So it's at least 10 years behind the adult population in terms of doing good quality research. But in Australia, we were the first, as I mentioned, we were the first country to endorse the use of exercise in cancer care. So we've recommended for all clinicians and nurses, anyone involved with caring for cancer patients, to at least discuss that exercise should be part of your treatment. And if you feel that they need a referral, you can refer them to an exercise physiologist or a physiotherapist. So in Australia, and I'll talk about this, but in Australia, anyone with a chronic disease, can be any condition, can see an exercise physiologist or a physiotherapist up to 5 times a year, covered by Medicare. So the government will pay, which is really lucky that we have that. In the US, I don't think that's the case, but private health might cover these types of services. I'm not sure. Maybe there's more funded services that are being done in hospitals, or donors are funding these type of services as well. But I think it'd be fantastic if the US can copy what we do, and because it's an investment in health, basically. Now we're seeing with this investment, can these patients get back to work? Can they live longer? Can they cost the public healthcare system less because they're less sick? So it's an investment. And the guidelines, I said it the same as the healthy population guidelines, which are around 150 minutes a week of moderate exercise or 75 minutes of vigorous. Now, again, people often might get scared about that, but 150 minutes of moderate, or at least moderate exercise for someone going through cancer treatment is not the same as moderate exercise for someone who's not going through cancer treatment. So their perceived exertion is going to be, it's going to be harder for them to do simpler tasks, basically, and that's fine. So it's all to their own level. They don't have to expect to be able to do CrossFit or something extremely challenging, just moderate for their own levels. But they also suggest to do resistance training to preserve muscle mass. So 2 to 3 times a week of resistance exercise. Again, can be in a gym, doesn't have to be. Can be resistance bands. They're cheap. Can be squats. It doesn't have to have using your body weight. It can be using tin cans or gallon of milk. About gallons. And here's a busy slide as well, I guess, to show the role of what we perceive as exercise in cancer care, and I'll refer down to the bottom. So this is a clinical pathway for assessing and managing peripheral neuropathy in cancer care. It's a really hard condition to pick up the nerve damage in patients. So what we've suggested is at every cycle that patients coming in to ask them just a 2-item questionnaire about how bad their symptoms are or their nerve damage, is there tingling, numbness, and basically if they're having symptoms, then we give them a bigger questionnaire to say, is there any functional problems? Are you having difficulty picking up things or walking upstairs or anything like that? And that tells us that they're having problems with physical function. And if they are, then we can go down to the bottom. I can do this one, which basically says, at this point, this is when patients with these treatments need to be referred to allied health. So exercise physiology, physio, occupational therapy to help deal with these physical issues. And this was recently published as well. So we're implementing this in Sydney in a few different hospitals as a research project now to see if it's feasible. It's very difficult to change clinical practice, but it's something that we're trying to do. And hopefully this can improve the outcomes for this population. ESSA is Exercise and Sports Science Australia. That's where we are all accredited with any exercise physiologists. So if we want to see patients with chronic health conditions and receive these Medicare rebates, so the government paying for it, we need to be accredited with ESSA, kind of like the American College of Sports Medicine here. We need to keep up our education every year. We need to do CPR training, and that way we can be eligible for these conditions. We also have sports scientists. It's a completely different profession, but also accredited under the same banner. They'll work with sports clubs. In Australia, there's less money for sport like there is here in the US, so there's not that many sports scientists. But there's more and more exercise physiologists because the government is willing to pay for it. And in Australia, there's 200,000 new cancer diagnoses every year. So there's going to be lots of work as this becomes more standard of care. So I want to allude to these slides. Even though this is Australia-centric, I want you to think about your own health system and how cancer patients and survivors in the US can get active through whatever is available to them. So in Australia, a lot of the care is managed by a GP or a PCP here in the US. And all patients, as I mentioned, will be able to access the Medicare, which is the 5 free sessions. But a big barrier is a lot of the GPs or PCPs aren't actually aware that patients are eligible, or they don't think it's a priority, or the patient's coming in for another issue, so they're not even thinking about exercise. So we really have to flip that because the PCPs are the gatekeepers. They're the only ones that can activate it. So the patient might have been seeing their oncologist for the last 3 or 6 months, and they might not have even been going to their PCP, but the oncologist can't activate these 5 free sessions. The PCP has to. Extra appointment, and that can also be a barrier. So implementing this model into our standard pathways is really the next step, but it needs to be done. So we also have DVA, Department of Veteran Affairs. So I guess same thing for you in the US. I think you've got a lot of veteran benefits, health benefits, so they can get up to 12 sessions a year if they've been in the Army or the Navy. So it's again something to look into. Work cover is if you've had an injury at work, so it's not really related for cancer, but if you fall off a ladder at work, you can get lots of sessions provided. Most private health insurers in Australia will cover exercise physiology, and people don't even know about it. They're paying for it, and they don't even realize. So they can get even more sessions. And obviously they can pay out their own pocket, but every time it might be $100 or whatever it is. And that might be fine for a lot of people, but when we're talking about en masse and all different socioeconomic status populations, it works for some, but not for all. But a real goal is to work towards self-management. 5 sessions is not a lot. One session is your assessment and exercise prescription, and then you might check in every couple of weeks and adapt the program, make it a bit more challenging and spread that out over maybe 12 weeks. The goal is to work towards self-management. So if you can have someone that's doing their own exercises, hitting their own targets, and being able to make their own program a bit more challenging by themselves, is the winning ticket with the system that we have available. There also are lots of community programs out there as well. Just trying to find them is the challenge. But that's also, so I guess that's what we have in Australia. And I don't know what you have here in Hawaii, but it's trying to piece together what is available and advertising that to the population. As I said, that's the Medicare is the biggest opportunity, but actually making it happen is not easy. I think only about 1% of GP referrals end up with a referral to exercise physiology, which is low considering, in Australia and the US, it's like 2/3 of people are overweight or obese, and the rates of diabetes are increasing. So even though you're seeing the doctor for another issue, I think that these doctors also need to be talking about, do you want to see an exercise physiologist to manage your health for all these other conditions that you have? At least for cancer patients. So this is, I was finishing my master's, and this article came out and was really showed the power of exercise in this large epidemiological study. And it basically says, if you're doing 9 med hours a week, so it's about 150 minutes a week of vigorous, and I think it's about 75 minutes a week of vigorous intensity exercise. So the health guidelines, if you're achieving that, you have significantly lower likelihood of developing cardiovascular disease years after treatment. So it comes back down to, you can really take control of your health and live a longer and better life. But we know that obviously once you diagnose, there's a lot going on, the unknown, and surgery and chemo, there's lots going on. So we do expect to see decreases in exercise. But for me, it's if we can, instead of our expected physical function to drop from here down to here, even if we do very light intensity exercise during treatment, we can slow that decrease down. So when we start up again post-treatment, the level of baseline is a lot higher. So it's really important to target that during treatment stage of exercise. And we wrote a systematic review a number of years ago. That's actually been cited quite a lot because it's not just about doing exercise, it's about how to overcome individual barriers, like what drives people, what are the barriers that individuals are facing, so we can write them a program that they can actually sustain long-term. Because we know it's not enough to just tell people to do exercise. We really have to get to that psychological, understand what makes them tick and what are the issues. So we identified that, as expected, the main issues are side effects, treatment side effects, comorbidities. So these are barriers for getting people active. But the number 2 barrier was fatigue again. And you hear it all the time. I'm just too tired. There's so much going on. I just want to be in bed all day. But then there's more and more evidence. Every study, so many studies are being published showing exercise actually reduces that fatigue. So it's a real difficult hurdle to start. Those first 2-3 weeks of getting someone to start exercise with significant fatigue is a challenge. But we can take simple, small steps We can call it activity pacing, where we just do a little bit, and the next week a little bit more, next week a little bit more. And then by, a month or two later, that jump is a lot, but the week to week might not be a lot. And that's okay. And the third most common barrier was too busy. I'm too busy to do exercise. And, when you think about all the benefits that I've said so far in terms of quality of life, quantity of life, all these considerations, is time a big barrier here? Like, should we find ways to fit into your life? Because it probably is a priority, something you can control. So, can we get off the bus earlier? Can we do 5 minutes at home? Can we do, can you do a walking meeting, for work? Walking meetings are great. You can walk and talk. You don't have to always be at a desk. I know that I'm at a desk often, sometimes 8 hours is terrible. But if we can do a walking meeting, at least you get some incidental exercise. I think that's really important. In children, again, going back to the children, we know that the evidence is much smaller because there's not a lot of high-powered quality studies. So that actual evidence for kids is less convincing, but we do know it probably will improve physical fitness, body composition, flexibility, strength, quality of life. So a lot of these smaller studies are showing that. We don't have the evidence like in adults. And I guess in children, it's a bit more limited because, again, the clinicians and nurses are asking, what should we do? What do the guidelines say? Sure, we don't know, because all these studies are being published are like 50 children and all different cancer diagnoses, and they're all different ages, 8-year-old and 18-year-old, and they get different exercise prescriptions. So it's very difficult to do good quality research. But the most recent guidelines that were published was basically saying, do anything, just move, do what you can, do it when you can. All children should be able to do it. Even if they're in bed, because sometimes in hospital, they're in bed for 23 hours a day. You can do stuff in bed. You can get cycling, like there's little recumbent cycles, or just foot pedals. You can throw a basketball, like just a small ball into a hoop, do some band exercises while lying down. There's plenty to do at home or in bed. And I guess all settings, it's important to promote this. So in hospital, in community, so going back to school sport, going back to school and doing sport. That's a really important one for kids because they go back to school and the teachers are like, I don't know what to do. And the PE teachers are like, I actually don't know what to do. Like, is it unsafe? Is it safe? Sometimes the kid is just the referee because the teachers are too scared to push them. Parents are too scared to push them. But if you keep wrapping them in cotton wool, their issues get worse and worse over time. And children who've had cancer are up to 15 times more likely to get heart disease than their non-cancer peers. So they really have to start young to develop good lifestyle behaviors. And the last statement is, movement might feel different every day, and that's fine. So they might be feeling fine one day, they might feel crummy the next day. That's fine. So just do what you can on a day-to-day basis. So this is okay. At least there is something. I think it's, it will be more helpful in the future to have, disease-specific or age-specific suggestions. So, when you look at that particular document, you can say, well, I've got a 13-year-old kid with leukemia, what's good for that child? But again, it's not easy to do because that kid might be interested in soccer, and then the child next to them might hate sport and dislike art. What do you do with them? Someone who's not interested. So it's really challenging to have a blanket recommendation for everyone. We looked at, in my PhD, I looked at physical activity levels. So just how much were kids doing after they finished their cancer treatment. And then I also looked at a cohort of adults after they finished treatment for childhood cancer. They might have had cancer when they were 5 and we assessed them when they were 40. And we found that actually the childhood cancer survivors were doing more than the controls. So in general, children aren't meeting exercise recommendations in Australia and the US. It's really bad, and those levels are getting worse. PE is not a standard part of the curriculum. I think it's being removed from a lot of curriculums. Kids are on their phone, adults are on their phones too, but kids are on their phones a lot now. And some places like in Memphis, it was just hot, 100 degrees every day. You can't go outside, and the neighborhoods are unsafe. is a big issue in a lot of places about being able to safely exercise. But we found in this population about 70% of your kids are not meeting guidelines. And when we know they're going to have lifelong health problems, it's a priority to get them active and starting this active lifestyle early. But even though those 30% were reaching the guidelines, a lot of these kids were having a good amount. So the blue is the childhood cancer survivors and the reds are the controls, so the non-cancer patients. The high amount of exercise that was achieved at the beginning when kids were still teenagers really decreased sharply in each decade of life after treatment. And that probably coincides with the increase in health issues that these kids have. So diabetes and heart disease, they're all common in the 30s and 40s for this population because of their treatment, which will make exercise harder as well. So we need to, again, intervene earlier because of all their issues. We did fitness tests on just over 200 kids. So VO2 max tests. I don't know if anyone's ever done this. It's a treadmill test. You're strapped up to a metabolic cart, like in the picture here, and you work till exhaustion. It's fantastic. I love it. The kids love it. Surprisingly, the kids actually didn't mind it. So we looked at these kids at least 1 year off treatment, and they worked to their maximum heart rate. They worked really hard. A lot of the parents were not sure how their kid would go because they never pushed themselves. But this is, we did it in a safe, controlled environment with medical supervision, very strict parameters, safety parameters. And this is a good test because there's no cheating. Like we're going to get a physiological response and we're going to see where your fitness is at. There's no lying or beating the test. Everyone will finish at a point. And it's called a VO2 max. It's your fitness. And that significantly correlates with risk of mortality, risk of heart disease. And we can improve your VO2 max with exercise, particularly aerobic exercise. So most of the kids performed quite poorly, as you'd expect after cancer treatment. And the mean was under the 30th percentile. So a lot of work to do in this population. I mean, don't get me wrong. I had this one state level triathlete that he just wouldn't stop. He just kept running. I couldn't believe what I was seeing. But the overwhelming majority need support in this population. It was safe. And that's another thing, it's not done much, this type of test, but it's more and more being done. And so I did this study in collaboration with St. Jude in Memphis, and we found it was safe. There's no issues in this population. They were all able to do it, but it's expensive and it's time consuming. So these metabolic carts, they can cost like $50,000 or $30,000. In my hospital, we needed medical supervision at all times. So, that was a barrier. You need trained personnel. You need, the setup takes time. So it's not practical to suggest that everyone do this. So can we do a different test, a different aerobic test, like a submaximal bike test or a 6-minute walk test or a 3-minute step test that anyone can do? And, a smaller island in Hawaii that doesn't have these facilities or somewhere remote in Australia. 6-minute walk test, all you need is a stopwatch and a pen so, and then you can compare how many meters. It's often a 20-meter corridor. Compare how many meters that they do, and you can compare them to age and gender percentiles. And then again, we can see how they performed, and then you can track them every 3 months and see if they're improving. So we found that it was a pretty good correlation. So basically, if you perform well in the VO2 max test, you perform well in the walking test. Obviously not perfect, but it was still a pretty good indication. We also asked kids, what are their barriers to exercise? Because that's important. And most of them, again, are saying, I'm too tired. Maybe they're tired anyway. We had a lot of teenagers as well. They're always tired. Of course, they'd rather watch TV. I would too. I just finished Stranger Things and some other things on Netflix. And I love watching TV, but can you do both? Can you do your exercise? Just playing. Like for me, kids, it's just playing. Kids can play if they're younger, dancing, running around. It doesn't have to be structured. But the teenagers, once they get teenagers, they might like a bit more structure. Again, no time. Can we ride a bike to school? Can we do something with the family? Because a pretty strong indicator of kids being active is their parents being active too. So can we do things as a family? I think is also really quite important. And unsure what to do. So there's a role of the health professional to guide them. Say, well, this is where we can start. And here are some suggestions of what you can safely do. All allied health can help in this situation. I also did my master's research was looking at exercise during chemotherapy for women with relapsed ovarian cancer, and no one in the world had done this project before, so I really was thrown in the deep end, and I learned on the job, which is, really, it was a really rewarding project to do. I think reflecting back, I realized it was a challenging project to do, but it's good to be involved in that group. And the most thing was, is it feasible for this population to train during treatment in terms of adherence, in terms of retention, and is it safe? And we found it was safe. There was no issues. No one had any adverse events. It was feasible for most women. I think it was about 70% stayed in the program, 30% dropped out because for some it is a lot. During treatment, some relapsed, one passed away. So it was, it's not feasible for all. But those who stayed in the program, they had improvements in their strength, quality of life, fatigue. And a lot of these were non-exercises. Some had done exercise before, that's fine. But for me, my greatest achievements I found was converting those who had never done exercise and actually enjoy it. And I remember I came back a year later to this clinic, and there's a student-led clinic in Sydney. And this one lady who gave me a lot of hard time when I walked into the clinic, I said, I'm David, I'm doing this research program, doing exercise. She laughed at me. She goes, no chance, I'm not doing exercise. And then in the clinic, other people joined the study and they started feeling pretty good. And then after like 3 or 4 weeks, she said, actually, can I join the study still? And she was tough, but once she got the hang of it, she really enjoyed it. She had really bad neuropathy. She liked, is it polo? No, what's the one where you hit the little ball through the, I don't know, it's kind of like lawn balls, but with a stick. I don't know what it's called. Croquet, that's the one. Yeah. Okay. Yeah. Yeah. Oh. Yeah. That's common, yeah. Fantastic. Yeah. You need to be the poster person, I think, for like exercise oncology. Yeah. Yeah. No, that's really powerful what you just said. And I guess your situation is different because you were exercising already for 22 years, but it's amazing that you kept going and you didn't throw in the towel. It's great that you got the support during COVID, and COVID was a big problem for a lot of people in delivering healthcare remotely, something that wasn't really ever done before, and everyone had to adapt. And brilliant. Yeah, it's really helpful when the clinicians support exercise or endorse it. I find that if the doctors say it's helpful, it's very easy to send that message. But if the chief doctor or looking after the patient is not sending that message, it's very hard to convince because they'll say, oh, it's another thing to do. So it's good that you got that support. Brilliant story. I'd be curious to hear about how you felt with this concept. This is called, I'm just mindful of time as well. I think I'm good at the moment. So chemotherapy periodized exercise. And this is something I was actually doing before. This is my program A, program B thing I was talking about. You might feel fine before treatment, and then after treatment, you might feel crummy, and that will continually fluctuate. Depends on your treatment cycles. Did you ever have sort of two different programs or different intensities?
As the annual physical, and I'd like to see that happen for every high schooler in America. That's really
Yeah. But I wonder, like, do you think you could even go for a 5-minute walk or something like that in that time? It says something better than nothing. Maybe not your gym program, but something little. So this concept of chemoperiodized exercises, I guess, a growing concept that we need to really work with patients during their treatment. This is going back to neuropathy. I'll just fly over this because neuropathies are growing. I mean, it's a concern. It really is a big concern. But every drug under the sun has been tried. There's been like 30 drugs that have tried and failed to prevent CIPN, to treat CIPN. None of them are working really with good evidence. Now other supportive care things are being tried, like exercise, acupuncture, massage. None of them really super helpful, but exercise may be protective, maybe not, but there's some evidence looking into this at the moment. Again, it's hard to do research in this. But in terms of for CIPN, these are some different exercises, just like general population, strength exercise, balance, aerobic is still important to keep that up. I had a patient, he was quite young. He was only about 50, I think 45, 50. He used to be top 5 boxer in Australia. And him and his friend were both diagnosed with colorectal cancer, and his friend had no symptoms, and he had the worst symptoms I've seen. And he loved surfing, and he couldn't even stand up on his board anymore, kept falling over, and he couldn't box because it was too painful. So we would do dynamic exercise. We'd put 2 Dura discs on the floor, little squishy discs, and replicate jumping onto a board. Jumping, and he would fall off every time. We tried for weeks and weeks and weeks, and eventually he got better at it, but he was able to do surfing about 3 months later. So for him, that was his goal. It doesn't always have to be just straight exercise. It's good to work towards a physical goal. But with patients, we do want to have safety considerations. I think COVID has been really good for safety considerations for the general population, because we know that, for cancer patients, there are a lot of safety considerations, washing hands, masks if you're sick. So avoiding busy gyms or busy pools during treatment might be important. Post-surgery, it might be good to get some clearance from their treating doctor to say when's a good time to start exercising. But sometimes they might be very conservative and say, 12 weeks, something like a really long amount without it might be too conservative. Even bone metastases, a recent systematic review and clinical guidelines came out for bone metastases because no one knew what to do in this population. And I think in general, they've found that all the studies that have looked into it show that it's still safe and feasible for people with bone metastases to be exercising. I'll fly over these as well, but these are just some other safety considerations. Kids and adults, if you've got a tube, a nasogastric tube for nutrition, you might want to be cautious about some high intensity or bouncing exercises if the person has anxiety about displacing it. And a port as well might be surgically implanted. So generally it's safe to do exercise, working with that patient again about comfort levels. What's a comfort, like a movement that's okay for them, but generally getting clearance from the treating team if they're concerned. We've got poor balance, things like, we don't have tripping hazards around the place. Maybe balance exercise will be good. So a range of issues give poor balance. If cognitive dysfunction is an issue, can we do very simple tasks? It's important. Or maybe like if stability is a problem, like a recumbent bike where they can't fall over. Graded exercise is important for fatigue. So just slowly increasing over time in both duration, so in minutes and intensity. So you can use a 1 to 10 intensity scale. You can use heart rate to monitor heart rate. But I think what's most important is what we need to keep raising the profile of exercise in cancer care is to really keep working hard professionally. So taking really good notes, treatment histories, comorbidities, and understanding the risks and feeding that back in with the treatment team. If we've got a good relationship with the treatment team, and showing what we're doing is safe and effective. That's really important in raising our profile. We'll keep getting referrals, and we'll keep being able to work together is really important. Using technology is important. Fitbits are great. Kids love Fitbits. I don't know, TikTok, like there's ways to get exercise. I don't know anything about TikTok, but like kids are watching YouTube and TikTok for videos. And even with COVID, you know, we were doing a lot of YouTube on yoga on YouTube for a while whilst that was happening. So I think it's good if we dial into technology, which people are really using. And you can ask questions, you can do questionnaires on some particular apps as well. People who want to start doing walking or running again, Couch to 5K, that's a really good app to slowly increase your running endurance as well. So there's ways to do that. And as I mentioned, it's just a little schema, just good questions to ask after patients during their treatment. But importantly, asking about what they like. What do you like? What do you not like? So I can write a program about that. And what are your goals? What do you want to be able to achieve in 3 months and 6 months, 12 months? So you can work towards that. And I'll finish up here. So we did this in children as well. I saw 100 kids and we did an exercise physiologist consultation. We said, you know, how much exercise are you doing? What do you like? What don't you like? If their fitness results were good, I just gave encouragement. And if they weren't good, I didn't sugarcoat it. I said, you know, there's room for improvement. And we did SMART goals and we gave individualized suggestions. And then we sent it to the doctor and the nurse and the parents. So they're all looped in on how the child was going and what they can do. And everyone was satisfied with it. Nearly all the parents and kids said all kids should get this. Like this shouldn't be just because it's a study. This should be standard of care. And that's what we're trying to do now in Australia, is trying to get the government to pay for this in the hospitals. And because we can promote it from a distance, this was a meta-analysis we did. And this was before COVID, because in Australia, everyone's far away. And you know, maybe in Hawaii, everyone's far away from the local centers. So we can't expect people to keep coming back here. We need to have a blended model where they come a little bit, but then also we can keep in touch remotely. And we found that people were staying in studies, and this was even before COVID, when exercise was delivered remotely. So there's a big effort that's needed here, not in just Hawaii, but around the world, and linking the tertiary centers with schools or community centers or exercise professionals in the community, and sport teams, even work organizations. I don't know, thinking outside the box to continue delivering that message that exercise is safe and important, safe and helpful. Lots of different resources out there which I can share. But yeah, basically exercise is safe during and after treatment, and it will help improve symptoms. It definitely will, physical and psychological. Individualized programs are probably more effective than blanket approaches. So targeting what patients actually want, using aerobic and strength exercise generally, balance for those who need it. And again, just keep really taking great notes and trying to embed ourselves in with the regular clinical team to show that, you know, what we do is safe and effective and will help the patients to keep raising the profile. But that's it. That's all I have for you today. So I hope there's good discussion and questions. And thank you again for having me. It's been a pleasure.
It would be perfect to have some kind of app-based program to, you know, particularly the young kids. I know there are several exercise apps that they built that's linked with Fitbit, and then it also has a capability to loop in like parents and you know, care providers, and then even like link up so you can see how other people are doing. So have you thought about doing that, or have you tested something like that?
Yeah, that's a good question. I haven't actually tested anything like that. I think that's the next big step. So we are looking to do a pedometer-based intervention for cancer survivors in Australia, breast and prostate. It's a grant that we're writing, that the information will loop back into the PCP, and the information can go to a a significant other, like if it's a partner or daughter or son, parent, or that type of thing. So the information can be shared if they want as well to help motivationally. I think that's a really important next step to loop in the healthcare providers. And it's something that we haven't done very well yet. It's something that's trying to be done in one of our private cancer centers in Australia, where they have much more control of their medical records to link in like Fitbit data into their medical records. So they'll come into the clinic and doctor will say, oh, you've only been doing 500 steps a day. But the public hospitals, it's very difficult to change the medical records and get that access. So I think that's definitely something to work towards. But if you have suggestions, I would love to hear about what apps.
For these sort of children's exercise apps, they don't really need a lot of medical record or medical information. I mean, the doctor can hold on to it, he just gets looped in. But the rest of the people kind of sees what exercise levels and how much activities and how they compare to other people, and then how parents can also, be part of the exercise SCUI kind of thing. So I thought, particularly for young kids who are very into technology, I've seen a few exercise apps that has shown to work really well.
Yeah.
So I thought that, maybe if you can adapt or do something that's specifically developed for cancer patients, young ones, and then maybe test it out. I think
Yeah. I mean, particularly for kids, it's super important. So St. Jude they've got a randomized trial now looking at gamification. So it's an app and they can get coins for every time they reach enough steps or whatever. They have set particular goals. And if they get the goal, they get the coins. And that seems to be working. I think they're getting really good results from that, even though it's not finished. In Sydney, we piloted a study called iBounce, which was piloted in French Polynesia. Sorry, in somewhere not far away from here. We're in Polynesia, not far away, just your neighbors. And it was piloted in healthy kids there, and we adapted it for a childhood cancer population with some education as well about their condition. And that was only a single arm study, but it's shown to be like good uptake and good adherence in that population. Again, the difficulty is getting the content right for the age group. So this was 8 to 12, and it was like a little bit hard for the 8-year-olds. And by the time they were 12, they're a little bit bored of it. So it's like the maturity levels are so different, and it costs money to make a really good, well-designed app for all the ages. But I think it's the way it needs to go.
Hi, nice talk, but learned a lot. I have just a general question about exercise, and just from my anecdotal experience. I live in a high-rise building, and we have a small but decent gym in the building, and the gym seems much less popular now. Ever since COVID started, I thought, when COVID started, a lot of the commercial gyms closed, and I thought, oh, maybe our little private gym would become more popular. I was concerned actually that it would get too crowded, but that didn't happen, and now there's no restrictions. The other gyms are open, but the gym is less popular than ever, and the only people I see there are the people from before COVID. The real long-term gym addicts. Who go there. There's no new faces. Anyhow, this just maybe it's just me, but any thoughts about that?
No, I think COVID has had real behavior change on people. Fear of going out, but also like it takes 2-3 months to have behavior change, whether it's good behavior change, but it can also be bad behavior change. Where it's so long of being in isolation, a lot of people aren't going back to the gym. Maybe save money from going to the gym, but in your center, like in your apartment, they're already paying for it anyway. But the behavior has changed in a negative way, and it's good for you if you want to use the gym because it's quiet. But for everyone else, it is concerning. There's been lots of published studies that have shown that the behavior trends, physical activity trends have decreased with COVID. So it's, that's a problem that we're having to deal with. Like we're going to see a flurry, we were going to see a flurry of new cancer diagnoses because like all the screening tests weren't happening because of COVID, at least in Australia for a while. But also people's lifestyles have changed, and, we're going to see a lot of increases in lifestyle related cancers, I think, too, with this. So it's going to need a big public push, I think, to get back on track. Do you have a question as well?
Yeah. I thought this was an excellent colloquium, Marty. As Pat said, It's not, as you said, a lot of these things we knew, or some of us knew some of them. Probably one or two of us knew all of them, but seeing the package together and how exercise can be integrated into a whole cancer program, I thought was a valuable experience for me. You supported it with real evidence. I have a specific question. You cited a paper by Cormier in epidemiologic reviews. The exercise was related to lower risk of mortality. I presume I got that right.
Yep.
I'm assuming that's with general population studies. Yeah, not clinical studies with smaller samples, because the mortality is fortunately a rare occurrence. You'd have to have a general population to see an effect on mortality. Am I correct about that?
So I think these large epidemiological studies with cancer survivors, and they've followed them for years. And I think they're looking at linked data. So when it's linked to death records, and they might have had questionnaires and they follow them for many years, it's not clinical research. So it's not like randomized trials, which they're trying to do now. So there's the challenge trial, which is, I think, led from Canada, Kerry Cornier's group, and we have sites in Australia where they're actually looking at randomized exercise versus no exercise on survival outcomes. That'll be probably a better level of evidence than the epidemiological research, because there could be reverse causation that they might be more sick, so they're less likely to do exercise, and that's why they're passing away. So I think it's a good guide, the epidemiological research, but I think we need to have caution with the statistics that I presented about that.
Right. Okay, but you corrected my understanding that Cormier review was of cancer survivors, not just general population.
Cancer survivors, yeah.
Oh, okay.
Yeah, so cancer survivors, once they're reaching the exercise guidelines, are less likely to pass away, or like lower mortality risk and lower recurrence risk, but with caution, because there's reverse causality as well.
I have one question. What's the perception among cancer patients in general about the benefits of exercise for better survivorship outcomes? Is there any data?
Yeah, that's a good question. And I think we're seeing more and more the evidence is increasing. More groups, like for us, Cancer Council is like your American Cancer Society. They're very pro-exercise. So all the pamphlets that patients get when they're diagnosed, it's one of the things in there. Exercise will help you XXX, feel better, lower mortality risk, lower recurrence risk. The info is in there, which is really powerful. So a lot of people are already aware of it. A lot of doctors now are aware and supportive, and nurses as well. So at least in Australia, we're getting that message out there, which is good. But then it comes back to is a blanket bit of education enough for behavior change? Probably not. And that's why either the professionals, physiotherapists or OTs or exercise physiologists in hospitals, or referring patients on is the next logical step, because medical oncologists aren't trained in exercise prescription. They don't know what type of exercise is beneficial. So, and they can't know everything. And even nurses, like a lot of them are well-meaning, and they might, have some good tips, but they're not as specialized as a physiotherapist or exercise physiologist in exercise prescription. So referring those on that is needed. But I don't know what the situation is like here in the US. Like, are patients aware? Is the message being sent in terms of like?
I don't know yet.
Very nice talk. I just follow up upon the comments you just made. Actually, in the US, there are cancer hospitals, they try to incorporate exercise protocol into the standard care of oncology. As I know, there are several NIH-funded studies ongoing to look at the benefits, because they think, as you said, that the exercise is really beneficial for the cancer survivor in terms of improving their physical condition, their response to treatment, and the overall condition and the survival. So, I also have two questions. One is, do you know any treatment-specific exercise program or critical, like you mentioned a lot of chemotherapy related symptom release or improvement. Any radiation specific exercise protocol or programs? That's one question. The second question, any biomarkers which allows you to monitor the effect or beneficial of the exercise besides those general metabolic markers or cardiovascular markers? Thank you.
Great questions. I'm not entirely sure I've got the answers in advance, but exercise immunology is a growing field. Looking at biological responses to exercise. It's not a field that I am working in, but it's certainly an important and growing field, looking at what are the mechanisms that are occurring, what are the protective mechanisms that are happening, inflammation and a range of different biomarkers that are changing with exercise or protecting the body. I can't comment on them because it's not my field. I'm sorry. In terms of radiation as well, I'm not actually working with radiation much. Most of my work's with chemotherapy. But it's probably a field that is actually less behind. It's more behind. Most literature is looking at exercise for people during the chemotherapy and less so about radiation. I think it comes down to the individual. What are the symptoms that they're experiencing? What is the site of radiation? Is there scar tissue that's causing pain at a particular site, like breast cancer? It might be around the shoulder joint. So probably shoulder stretching is important, and strengthening around those joints is important because those patients can have reduced mobility and strength, physical function in those joints. And obviously, having arm range of motion is really important for like nearly all movements. So I think upper body exercising, strength exercise, stretching is really important. Again, depends on the site of the radiation. And in kids or brain cancers, if you have cranial radiotherapy, that can cause metabolic issues and cognitive issues. So again, simple tasks, if there's cognitive issues there, would be important for that population. Because if kids are getting frustrated, or if anyone's getting frustrated because they can't throw and catch a ball, maybe we shouldn't be doing those type of activities and doing something a bit more less coordination based. So I think it comes back down to the individual's needs rather than having a blanket approach. But going back to, I guess, one of your questions about specific mechanisms. So there's some really exciting works like mouse models that have been looked at to say, can mice who are running on a wheel, who've been injected with a breast cancer tissue, for those ones that show that the tumor actually grows slower than mice who don't have a running wheel. So maybe exercise can act positively on the tumor. Maybe it's like decreasing the vascularization or some other mechanism that's slowing the decline down. It's obviously a lot harder to do that research in humans, but I know up in New York in Lee Jones's group, they give exercise bikes during the chemotherapy infusion, sitting there getting an infusion, they can ride a bike at the same time. And to show if maybe the uptake of their chemotherapy, it can be, or it's the pharmacogenesis, I guess the chemotherapy can be delivered more effectively. And Katie Schmitz and some other people as well have just been funded from an NIH grant to see if exercise can increase the relative dose intensity. So can people tolerate exercise during treatment? They can actually receive more of their chemo dose because they're fitter and healthier and they have less toxicity. And if they get a higher dose, they might survive longer as well. So that'll be like 3-4 years until we see that data, but that's a really exciting next step. And, if we get these good clinical data, these clinical studies showing these meaningful outputs, then doctors, I think, are more likely to prescribe it rather than just quality of life and the softer outcomes that we see, which is still important.
Cat question from Hallie Robnett, and she says, wonderful presentation. Can you please speak to how you, exercise physio champions in Australia, secured policy providing up to 5 covered exercise physio visits per patient per year?
Yes, I didn't put that slide up. We had, it's really hard to advocate for change from policy and government. And I'm not going to even begin to try and understand the US government system because it's complicated. But for us, you can go through the official channels, which can take years of campaigning. Or you can get one, all you need is one federal minister on your side. So we had one guy who 5 years later became our prime minister. But before then, no one even knew who he was. I think he was in charge of aged care. And all it needed was him to, we campaigned with the evidence for exercise as a group. Exercise Sports Science Australia campaigned to him with the evidence. And then he put forward to the rest of Parliament that Medicare should pay for this. So sometimes all you need is someone in position of power to support this. And, that could happen in the US. All needs is one congressperson to put this bill through, which, if it saves money, that's the main thing. If it's people going to live longer and better, maybe you guys will follow suit. So we only have 5 sessions, which is okay. But now we're campaigning for more. We're trying to see, because for some reason, diabetes gets an extra 8 sessions. Someone campaigned for that and was approved. I mean, most get knocked back, but if you don't ask, you don't get. So you got to sort of keep trying. And we're going to try to see in Australia if we can get more sessions. So that's something I'm doing with my role with COSA. And it's most of the time thankless, but all you need is one win, and that would be great for a lot of people.
Thank you. Great talk. Everyone is welcome to join us for lunch with Dr. Mizrahi at 401 upstairs.
Brilliant. Thank you so much for having me. Looking forward to chat and have lunch. Cheers.